Everything else depends on the cushion copy I can read from.
I have a feeling it might not, because this is the screen that you would normally see your notes on, and I can't get it to turn on, unfortunately. Which, it's all plugged in, but I don't know why it's not.
It was more dim than my presentation. But that's fine. I printed it out, flipped pages.
Sorry about that.
No, that's not a problem. Again, I'm prepared with this, and I'll just flip pages and look at the notes when they're appropriate.
Fantastic. And there is help please help yourself to a water bottle if you would like.
Thank you.
And then I think you're all ready to go. You just know how this one works.
Yeah. Very straightforward. I'm going to move this up here, and I can probably move the slides either with this or with that.
Yeah.
But you can't get any easier than that.
Yes, I just wanted to present you so you can see the audience and then the audience on one side. My computer's not working. So it's not going to work in my favour. No, it's not.
In a different place. Oh, wonderful.
Yeah, I agree. And we've got a very good
Looking forward to going over there. We've been caring about it for a long time.
So I believe on
You would think that would be, as we say, a slam dunk. But
yeah, that's right. I'm used to it.
Yes, bureaucracy is bureaucracy wherever you go.
Never changing, eh?
It has its good points, but not so often, not so obviously.
Now, how are we doing with the AV?
I think we're in good shape. Now, I wonder if you folks will need this before I do. The command voice.
I think.
Can we get a vote? We should get a vote. Who's in charge of AV?
But that young lady's helping with the AVX and that. The lady was a pink. Yeah, wouldn't be.
Congratulations.
Oh yes, Harrell Cutler. So nice to meet you.
Sebastian.
Yes.
This is great.
And Harold. And yeah, this is all. I'm still trying to figure out the agenda exactly for today, but
You know as much as I do then. I'm here to listen to your talk, and then I imagine if someone says my name, I pop up, we get a photo.
Oh, that's nice.
I think that might be the way it goes.
Well, all right. You're probably more photogenic than I am.
Appreciate that, but we'll make it work. I'm sure.
Well, I hope that we'll see if the talk fits, and I think it fits the frame.
I'm very interested because it's not in my field at all. So mine's nephrology. So we don't clash. We're just very different, but it'll be very interesting. I'm sure. I'll be very excited.
Well, nephrology used to interest me a great deal. Some of my first supervisors on medical rotations were nephrologists, and so I've always had a soft spot in my heart for them.
Nephrology. Well, I mean, I feel like neuro and are very exciting as well.
Well, actually, my very last rotation in medical school was an elective in nephrology. It was mostly, though, on the dialysis program. That in Brooklyn, New York, is one of the first dialysis programs.
Is that right?
A fellow named Eli Friedman invented one of the first home dialysis.
Peritoneal dialysis, or
no,
an actual
it was
fistula?
I want to say it was renal dialysis, but it was a home setup.
Wow.
stood on legs. It looked like one of those things that vendors have on the street that they pop up and the legs pop up, and there's this machine. And yeah, and he was a brilliant man and a great enthusiast. So again, a soft spot in my heart for that.
It's good. Nephrology, it's the way I've been told by my supervisor, it's the prince of professions, and that, you know, you've got your cardiacs, the king and whatnot, but the prince, they get to do what they like, you know, and the kidneys kind of have a role in everything, especially with the heart. I mean, hugely important in the heart and liver and whatnot. So.
Well, and always discovering something new that the kidneys are involved with that we didn't know before. But they're elegant. They're very elegant things, and you can't do without them.
Yes, well, that's very true. It's very true. But I'm very, very excited to listen to you talk.
Well, we'll see how it goes. I'm really looking forward to seeing again what reception it gets, and if these ideas have resonance here. And if I don't bore people to tears with talking about what we do in the U.S., you know, it's an interesting question as to when it becomes absolutely impolite to talk too much about what happens in the United States.
I don't know, it's hard to offend Australians in general, I think, but you're welcome to try.
Well, let me know if I seem to be crossing the line.
I'll give you a look over there.
Well, that's my wife's job.
Absolutely, no, she'll probably
She's
do
here.
She has a better look, I think, probably.
No, it's good. She has a lot of experience with that.
All right,
No,
I'll let you set up.
Thank you very much, and yeah, well, I may even have a seat here. We'll find out.
He's a very
Yeah, I was going to say,
Plus, let me give you a lecture. Oh, that one's not working yet.
Okay.
We established that.
good time there. It's quite small.
Squint a bit, yeah.
The thing I always fear is that's not
You, thanks.
Well, good evening everybody. Welcome. My name is Professor Benjamin Karl. I'm the newly commenced Executive Dean of the Faculty of Health and Medical Sciences. It's great to see you all here. I want to start by acknowledging and paying my respects to the Kaurna people, the traditional custodians whose ancestral lands we gather on tonight. We acknowledge the deep feelings and attachment and relationship of the Kaurna people to country. And we respect and value their past, present and ongoing connections to the land and their cultural beliefs. It's a real pleasure to welcome you here tonight to the annual Northern Communities Health Foundation lecture. This is actually my 5th day as Executive Dean and my first public event, so it's a real thrill. And as I said, it's wonderful to see you all here. Now, before the lecture, and we introduce our visiting professor and guest of honour, I'd like to introduce the chairman of the Northern Communities Health Foundation, Mr. Len Payne, who's going to be presenting the Derek Fruin Early Career Researcher Award. Len.
Professor Karl, thank you very much for the invitation. And formally, on behalf of the Northern Communities Health Foundation, the board, members, welcome you and thank you for coming to the annual NCHF public address, this year to be presented by Professor Harrell Cutler. This is the 16th annual public lecture, and hence the 16th time that we've had a visiting professor sponsored by the foundation. The program started in 2007. The visiting professorship program is one of several programs the foundation supports for the university. In addition to the VP program, we do support research projects and prizes for students, PhD top-up scholarships and other opportunities that we have to support the work of the university. The foundation was established in 1998 following the closure of the Northern Community Hospital that some of you may remember was based on Prospect Road, right next to Prospect Oval. The financial viability of the hospital came into significant question at the end of 1997, and it was decided to close the hospital. And from the the sale of the assets, the money that was left over from that process was invested in a trust, and a foundation was established with the objectives of promoting the health status of people in the northern communities of Adelaide. And the board since that time has been involved in quite a number of projects, both with the university and with the community. Some of our community projects have been in the area of mental health, which is the particular area of interest that we are concerned tonight. And we have a current project at the Playford Council, the Playford Suicide Prevention Program that the Foundation is supporting at this time. Coming back to the university programs, one of the programs that we are very proud to have established is the Derek Fruin Early Researcher Award. It's valued at $5,000 and is awarded to somebody in a field of Derek's own nomination, somebody who is excelling in their research activities and has enormous potential for research into future years. This year, the Early Researcher Award was given to somebody in the field of renal medicine. It's a prestigious award. Derek Fruin was the Executive Dean of the medical school for I don't know how many years. But we have come to love Derek as a member of the foundation, having been Vice Chairman for a number of years and Chairman of our Grants Committee. And so tonight it's a great privilege to announce that the winner of the Derek Fruin Award for 2019 is Dr. Sebastian Stead. And I invite Professor Fruin, Emeritus Professor Derek Fruin, to come and present the award to Sebastian.
Wonderful. Thank you very much. Thank you.
Finally, one of the things that the board, the Northern Communities Health Foundation, has achieved this year is the establishment of a research foundation to augment the NCHF. The board has, over the years since its inception, given out in the order of $1.5 million for research projects and other activities and awards that I've referred to earlier. Not an insubstantial amount of money when you consider that when the hospital was facing closure, it was predicted that it would have lost $1 million in the following year. So it's been quite a positive and a pleasing result that's come from the ashes of the hospital, if you like. So this year the board has determined that it now needs to grow to be able to support more projects and increasingly larger projects, particularly those associated with the university. And so a research foundation has been established, a website has been established, and we are ready to grow the foundation. So if you have any spare cash anytime, then you may wish to remember the website address down there, www.nchf.com.au. Not quite at the moment. The first donation will be received by the foundation at its annual general meeting in November by Mr. Frank Agostino, a prominent businessman here in Adelaide, who's committed to donate $5,000 per year for the next 5 years to establish the Research Foundation. So we're looking forward to a growth in the foundation and to be able to bring even more visiting professors to Adelaide to share their knowledge, such as our visiting professor is tonight. And our visiting professor is to be introduced by our Executive Dean, Professor Benjamin Karl.
Thank you, Len. Thank you, Len. Congratulations, Sebastian. There is no greater thrill than seeing young people with a bright future in research doing well. So it's a great honour, Sebastian, and we're thrilled to see you receive it. So this evening we hear from Dr. Harrell Cutler from the United States, visiting professor, courtesy of the Northern Communities Health Foundation. He is an internationally recognised expert in the treatment and research into trauma-induced stress. He's got a number of colleagues and collaborators here in Adelaide, in South Australia, but also in Australia more broadly. And it's a real honour to have him here with us tonight to talk about his work. He received his Doctor of Medicine from Downstate Medical Centre in Brooklyn, New York, and studied psychiatry, trained in psychiatry at Yale University. He joined the faculty of Duke University in 1984. At the same time, he joined the Veterans Affairs Department, which is a really big deal in the United States healthcare system. And since that time, he's, as I said, developed an international reputation, both as a clinician, as someone who treats trauma-induced stress, but someone who researches and tries to understand the causes and ways to treat trauma-induced stress He was the founding chair of the Post-Traumatic Stress Disorder Practice Guidelines Task Force of the International Society for Traumatic Stress Studies and the first author of the resultant guidelines. In 2014, he was appointed as Chief Mental Health Consultant to the United States Veteran Affairs Department and Acting Secretary under Deputy before retiring in June 2018. Dr. Kudler continues to serve on the Duke faculty and plays an active role in a number of national and international organisations. And as I said, it's a real honour and a thrill to have him here with us tonight. There will be time for questions after the presentation, but for now, please join me in welcoming Dr. Kudler to the podium.
And I seem to be on the air. All right, good. Thank you, Benjamin. Thank you, Len, and my thanks to the Northern Communities Health Foundation. In many ways, the history and mission of the Health Foundation are mirrored in the same issues that I hope to address here today. Again, if I start to talk like a native New Yorker, I am one, so if I go too fast, let me know. But we're here to talk about clinical and public health approaches to the mental health and well-being of service members, veterans, and their families, integration. I also want to take a moment to thank Doctors Jacqueline Elliott, Paula Dabovich, and also Josie Gray, who made this visit possible and did so much to help me prepare. So let's take this forward. I've already been introduced, again, 31 years as a psychiatrist working in clinics in our Department of Veterans Affairs. When I started out, the World War II and Korean War veterans and ex-prisoners of war of those wars that I work with were actually younger than I am today, which is a frightening idea for me. I went on eventually to become a national policy lead for the Department of Veterans Affairs. So anything that went right, but usually anything that went wrong in the area of mental health or was on the cover of some newspaper was my job to respond to in some way. And in the years I've lived in North Carolina, it's a state in which every branch of our military has a major base. The largest Army base in the United States is in North Carolina, about 90 miles from us. The second largest Marine base, with forces rotating into Iraq and Afghanistan every 6 months and coming home and then rotating again, is about 2 hours to our east. It is what they call themselves. Every state in the United States calls themselves the most military-friendly state in the nation, but North Carolina is certainly one of the most military-intense states, with 1 out of 10 people in our state being a veteran. And that would translate to probably another 2 out of 10 people in our state living under the same roof with one. It is part of our lives every day. Back in 2000, I chaired the Department of Veterans Affairs Undersecretary Special Committee on PTSD, which was actually created by Congress to make sure that the VA was up to snuff on clinical care, benefits, research, and education. And the year 2000, thinking about PTSD was largely a retrospective job. We were looking back at Vietnam and just barely paying attention to World War II and Korea, because PTSD was considered a Vietnam problem. By 2001, of course, with the attacks on the World Trade Center and the Pentagon, now PTSD was a prospective problem. Knowing that we're going to war, we had never taken the concept of PTSD and applied it prospectively. How do you prevent PTSD when you're sending a whole generation off to war? And we have now been at war for 18 years. So we have people who were just barely born when the attacks of September 11th happened, who are now already veterans of Iraq and or Afghanistan. It's an historic occasion to be in. And it's really what I want to talk to you about today. So I should introduce the Department of Veterans Affairs because, you know, again, to paraphrase George Bernard Shaw, Australia and the United States are two nations separated by a common language. And I very likely will use phrases you're familiar with in a way that means nothing at all in terms of the normal context. So our Department of Veterans Affairs has three components. The Veterans Health Administration, that's the health care part, and that's the part that I work in. The Veterans Benefits Administration, which gives college grants, sends people to college. My own father was the first person in his family ever to go to college, and that's because he was a veteran. It endorses mortgages for veterans, so they have a place to live and security and can build wealth over their lifetime. And we also run the world's largest cemetery program, the National Cemetery Administration. So we're very large with over 380,000 employees. We're the second largest department of the United States, and with an annual budget overall that's approaching $300 billion a year. If we drill down to our clinical services, we run 170 major medical centers across our nation, not just in the continental United States, but in places like Guam. We have 1,074 community-based outpatient clinics we built in the last 15 years, realizing that many people couldn't reach our brick-and-mortar hospitals because our nation is a good size. Not as big as yours, I think, but a good size, and it's hard to access those big medical centers. We also have 300 vet centers. And I was lucky enough that when I started as a resident in psychiatry, one of my first clinical supervisors, still a friend today, Art Blank, was just leaving for Washington to become the first director of the vet centers. He had been a psychiatrist in Vietnam during the war. And Art took on the mission of running these storefront operations, staffed for the most part by combat veterans, paid for by the VA, but not looking like the VA. Very informal, very few ties, no medicines prescribed, not clinics, but staffed by psychologists, social workers, peer counselors, and a drop-in place where veterans and their family members, anyone who'd ever served in a combat area of operations, could just drop in and get absolutely free services, whether or not they were enrolled in a VA hospital system. It was welcoming, it was local, it was peer-led for the most part, and it's a model that I want you to consider because we'll come back to it a bit later. Along these same, and since then they've bought 80 mobile vet centers. So the vet center program can now go to a natural disaster or a place like September 11th, the Pentagon, and park right outside and actually run a clinical operation with satellite telemetry to take everything back to the mothership if needed. Further, VA's hired, at this point I think we're over 1,400 peer support specialists. These are people who are veterans with a lived experience of a mental health problem, and they're becoming really essential to us in our ability to talk to veterans in their own language. Again, not everybody wants to talk to a psychiatrist. I know that will surprise you. But to have somebody who's really been there and talks your language has some of the same needs and experiences you have really makes a difference in providing access. You can build a hospital, and I've seen this happen right next to somebody's house, and they'll never go there. But if you have a peer support specialist, there's a very good chance they'll not only go, but they'll stick. And finally, we've created more telephone lines than anyone will ever remember or be able to track. But our Veterans Crisis Line has tracked hundreds of thousands of calls from veterans and is capable of locating a veteran on a mountaintop in Tennessee and sending emergency help to them if necessary. Thinking about VA care, if you follow the American news at all, we're always getting beaten up, and sometimes we need to get beaten up. It keeps us on our toes. But the VA provides mental health care, according to our National Academies of Science, Engineering, and Medicine, at a quality that's actually superior to other public and private providers. We run the largest mental health system in the nation, maybe in the world, and we're the biggest employer of psychiatrists, psychologists, social workers in the United States. There are 9 million enrolled veterans in our system of the 20 million living U.S. veterans. 6 million use our health services annually, and 1 in 4 will use a mental health service in any given year, and it's not the same 1 in 4. By the way, if the general public had access, in the U.S. at least, had access to mental health service at the level that veterans have much more access than the general public, I am sure they would be using, 1 in 4 would be using mental health services per year too. It's pretty much what we predict the average population is going to have in the average year. In 2017, more than 1.7 million veterans received care at a VA mental health program, which has doubled since 2006. And it's largely because we provided more capacity since 2006, not because veterans needed more help since 2006. Nearly a third of all these patients received care from mental health providers who are co-located and part of the teams of our primary care clinics. In the old days, primary care doc says, I think you might be depressed. I'm going to give you an appointment in a few weeks to see a psychiatrist. Come on back. And the veteran leaves saying, I'm not taking another day off from work. I'm not driving 90 miles. And I don't really want to see a psychiatrist anyway. Now the provider says, look, you seem to be having some problems with depression. I'm going to walk you down the hall and introduce you to my friend and colleague, and he's going to see you now. And this has been incredibly helpful in providing real access for mental health services and doing it proactively instead of after people are really in trouble. Now, I mentioned that in 2000 I became the co-chair, frankly I was the only co-chair, of the Undersecretary Special Committee on PTSD. That happens a lot. Seems to happen to me a great deal. But anyway, one of the things we decided to do is we needed to have data on what was happening with these new people coming back from Iraq and Afghanistan. And so with the Undersecretary's help, and I was in the room when he called this other fellow in, we got the head of our epidemiology service in the VA to begin quarterly reports, pulling together tons of data. And it is great to be a giant national entity which has tons of data and people who can analyze it. So we began reporting quarterly in the second quarter of in 2002. And this quarterly reporting continued through 2015 and followed over 1 million veterans coming in and out of Afghanistan. The data indicated service members, veterans, and veterans encountered significant problems engaging with our system, as well as DoD systems. Many of these people were reservists, so they're in the military when they're called up in the reserves, and they're veterans as soon as they get back, and then they go back in the military when they're called up again as reserves. So we had a lot of data on DoD folks as well, Department of Defense. Almost 60% of the veterans by our last count, our 2015, had received a mental health diagnosis. I don't think that's at all unusual in a combat area, because these include everything from moderate anxiety to PTSD, PTSD being the single most common diagnosis of people who rotate through a combat area. But depression, substance use, by the way, tobacco abuse, and I'm talking like smoking like a chimney, dwarfs all other forms of substance abuse. They don't even report it anymore in mental health because it makes the numbers look bad. But in fact, if you want to save lives, you deal with tobacco abuse early on. What we did find, though, is that as we got better at reaching out to people, for instance, we created what's called the post-deployment health assessment, and then our data showed us that people don't seem to have a mental health problem or want to talk about it when they first come back. So 6 months later, we now give them the post-deployment health reassessment. And at that time, their wives or husbands have usually said, if you don't tell your doctor you're having this problem, I'm out of here. And then they tell us the truth. And then they fill out the form, and they come into our system, and we begin to offer them services. As of 2003, we were beginning to realize we needed a new approach, because even then into 2005, more than half the veterans coming back from Iraq and Afghanistan were reporting problems, but they weren't coming in for help. You know, it's up to them. They don't have to come if they don't want to. But we didn't think that was very helpful for our nation or for them as individuals or for their families. So we began to develop new kinds of programs, including a VA research, education, and clinical center devoted to what we call deployment mental health as opposed to PTSD. PTSD is real. It's very important. However, it's too narrow a lens to understand what really happens in deployment. There are many other kinds of problems, many of which are not mental health disorders at all, but extremely destructive in the life of a veteran or their family. Further, in 2005, we had the first meeting of our local states group, the North Carolina Governor's Work Group. I'll tell you a little about that, because I'm very proud of that. And in our efforts working on this, I think we've learned some of the principles that I want to talk to you about today. For the first thing, it's a big tent. As opposed to our VA, which is this giant government agency which drills down and tells people what they're going to do, which is never pleasant for people. We just decided we'd pull as many partners together. This started with 6 people, 2 of us from the VA and 4 people from our governor's office, sitting around a table in the state government office saying, what are we going to do? To inviting as many people as we could possibly imagine might be interested in this issue to a very large kickoff meeting. And this began a set of meetings in 2005 that continue monthly to the present. Every single month since 2005 we've been meeting. The meetings are now chaired, since I left, I chaired it for about 11 years, but after I left it did better. It's now chaired by senior VA health and benefits leads for our region, as well as senior state government people like the head of the Department of Commerce, you know, about jobs and employment issues. It regularly includes over 5,000 virtual attendees every session, plus about 75 to 100 in the room. And it'll take on any issue at all vaguely related to veterans. And it allows possibilities for presentations by anybody who has even a remote interest in veterans. To give you an example, people who train service dogs and just bring them as a charity as opposed to the larger organizations that do it, or I'll always remember maybe my favorite, we have NASCAR. I know you have car racing because when I turn on the news here I see it. We have an American version of car racing, NASCAR, and one of the pit crews decided they would start hiring veterans, and not just any veterans. They would go to our PTSD inpatient unit at one of our psychiatric hospitals and say, we want the people who failed your program, the people you think are never getting out of here. And they give them a job, any job they want. It might be polishing cars, it might be fixing engines, it might be doing advertising and marketing for their business. And they have proven to a man and woman that those people actually rejoin life and get better in their symptoms if you give them something meaningful which they enjoy doing and which gives them a sense of efficacy and value in the world, which is a very important theme. You know, again, you can look at PTSD through a lot of lenses, and you need a lot of lenses to understand a problem like this, biological, psychological, and social. But it's wonderful when someone who is not too worried about being a psychiatrist is just trying to help, takes, in this case, a social lens and rebuilds people from the bottom up and shows that it can be done. And it can be done. So, let's see. Then in the next 7 years, we had a further shift of vision and mission based on these experiences, assuring that service members, veterans, their families are recognized and have access to military culturally competent as well as clinically competent care whenever and wherever they seek care. So this is a big problem in the U.S. We have a very strange health system, and Peter had a go at me about this, and he's absolutely right. Our VA system is a single-payer system, much like your national health. But most Americans don't have that. They all have different insurance policies with a dizzying array of services, and many are sort of there's non-access to mental health. It may say in writing you have access, but in fact you have no access to mental health care. And so many people are totally puzzled and give up quickly, which makes the insurance companies happy but doesn't help us as a society. Our system is designed to be a no wrong door system. What the governor's work group created is not just a bunch of people who present to each other, but literally thousands of people who know each other at this point, years into it. And when they hear about a problem, they say, I can't fix that, but I know somebody who can. And they pick up the phone and call them, and that person fixes the problem for this individual. And then everybody learns something, and then the next person, it's a facilitated pathway. It's highly individualized, but it has to be, because no two veterans are the same, even if they served in the same place at the same time. Their experiences are the same, and their needs will not be the same. Now, all this led to this idea of communities of care. And a friend of mine, who is a Department of Defense psychiatrist, Steve Koza, we worked together on Sesame Street. I know you have Sesame Street here too. We created a series. Steve really was a prime mover and I got to be a kibitzer. a series for military children. The first was about a parent who goes away for a long time and comes home. The second was a parent who comes home with visible or invisible injuries. And the third was on the death of a parent. A few years later, Steve called me up and said, look, we're putting together this special issue of a journal. And again, I can give you these slides and you can get the entire journal online if you like, The Future of Children. And I want you to write a chapter called On Communities of Care. And I said, Steve, that's great. What are communities of care? And he said, I thought you would know. That's how I summarize what you were talking about with the governor's focus and everything else, you know, the governor's work group. I said, oh, okay, well, we'll figure it out. And then he assigned his colleague, Army Colonel Rebecca Porter, to work with me. And together we wrote this chapter. And it calls for a public health approach that goes beyond clinical models that focus on service members, veterans, and their families as individuals, and harnesses the strengths of communities which surround them. And the fact is, again, I'm a doctor. I'm trained. You walk into my office, I examine you, I make a diagnosis, I institute a course of treatment, you get better or you don't get better, and I'll keep working with you until you do get better or you fire me. One of those things. Many patients I followed for 30 years in the VA. Working with them, and many of them were a great deal better, and some keeping them alive was an accomplishment. But a public health approach is a very different thing, and that's what we're going to be diving into. It requires making service members, veterans, and their families visible in civilian settings where they're not recognized. We did a study first in the VA, and then it was replicated by the RAND Corporation. RAND is a giant think tank that hires itself out to government, but can do any research they feel like doing. They're very well positioned. And RAND replicated our study at a much higher level and showed that the vast majority of civilian clinicians and clinicians in public health programs and private health programs never take a military history. Never ask the simple question, have you or someone close to you served in the military? A lot of doctors and other kinds of clinicians don't think that's a relevant question. You know, why would I want to get into that? Although, as one doctor said to me, look, I'm a small businessman as a doctor. Patient walks in my office, I got 15 minutes with that patient. If I ask him if he served in the military and he starts crying, then the 15 minutes are up. He doesn't get any treatment. I never even find out what he was there for. So why would I want to ask that question? But I can understand his position. But I think even that was motivated by the more common concern that I wouldn't know what to do with the answer. So if I knew you were a veteran, what would that mean to me? I don't know anything about it. And this is where the drive to develop military culturally competent care. Military culture is a true culture of its own. We spend a lot of time learning about other cultures. I really appreciate that we spoke of the native people whose land that we're standing on today. But we don't talk about military culture. And yet in the United States, I mentioned 20 million veterans, another 15 million people living with them who are under their roofs. If you were to ask the question, have you or someone close to you served in the military, 1 out of 6 Americans would answer yes. That to me is very relevant. And I think, frankly, it's our duty as members of our nation to be asking that question. The numbers are very different here in Australia. You have about 58,000 people in your military. We have 2.5 million. You have about 675,000 veterans. Only a small proportion of whom are actually enrolled in your veterans' health system. But I still think it would make a lot of sense, and I think it's the right thing to do. And I'm a great fan of the right thing to do. In our article, we began to envision, to try to frame all this, though, in written language. And this idea of that the spectrum of care for these folks has to go beyond the health system into schools, into colleges. We pay people to go to college, but we don't look after them when they're at college. Into workplaces. We have employee assistance programs, I imagine you do too. Educating those people, educating personnel staff, so when there are problems in the office, it might be the veteran is agitated and can't stay at their desk for long periods of time, or it might be the wife or husband of a veteran who's coming back, the veteran's just come back home or is coming back home, and the kids are having problems and things aren't working, and don't fire that person. Understand their issues and find ways to support them. religious institutions, research has shown that service members and veterans who are having problems with issues related to combat are 5 times more likely to tell a congregational leader about that problem than they are to tell a mental health professional. So we need to reach out to those people. Plus, the focus of local communities, and many of our veterans, like many of your veterans, are rural or highly rural. It's the church that runs that community. It's the public school that knows if the kid's having problems. And before you simply say, put that kid on Ritalin, you might ask the question, do they have a parent who's stationed overseas, or who came home missing an arm, or whose parents are getting divorced, related to stress that happened while they were separated for long periods of time. Those would be good things to know and to act upon. So the core idea, and this is right out of the article, is communities of care are defined as complex systems that work across individual, family, community, military, state, and national levels of organization to promote health and well-being. An effective community of care can be measured by its public awareness of service members, its ability to recognize their needs and support them in community settings, and the ease with which service members, veterans, and their families can access resources and services, and by no means reserved to medical systems. Medical systems are totally inadequate to manage what really is a public health problem. And not as a problem, a public health issue. Let's put it that way. Because a lot of this is normal. I mean, you know, you go away to a combat area for a year, and people are shooting at you. Your family members at home, and all kinds of things are going wrong, and the washing machine explodes, and the kids are having trouble at school. And you know, between the two of you, when you get back together, it's normal that things not feel very normal. And this needs to be understood. And there are many people who can help with this. If it was left to psychiatrists, everybody would be in a lot of trouble. One of the programs we developed for all of this is something called Painting a Moving Train. That's actually a quote from one of our Marine generals who said, trying to catch up with these wars that we're in is like trying to paint a moving train. We created a series of over 50-day-long trainings for health professionals where we trained them 50 times and got a national grant from a group not unlike the Northern Communities, a health foundation, through which we trained 20,000 providers nationwide. I have to tell you that seemed like quite an accomplishment at the time, but I found in the years since we did this, 20,000 providers is a drop in the bucket. It didn't move the needle at all. It really didn't change what was expected of health providers in America. And so that's why we're going bigger with this kind of a model. But through this program, we did make the effort to connect civilian support systems with Department of Defense and VA programs, from everything to mortgages, college training, vocational training, employee assistance, homelessness programs, etc. We also took the list of attendees, and we had thousands of attendees, and turned it into, with their permission, a comprehensive database with Google mapping to their offices and pictures from space of their offices, and all of their special interest in military and whether they had sliding scale and whether they had, in which courses they had taken and shown interest in, and put that on the web so that doctors could make referrals, so that school officials could make referrals, so that people could self-refer, so the kids could look it up for their parents. Family well-being is critical to the capability in the military. You have the Family Force and Veterans Initiative here. The National Vietnam Veteran Readjustment Study, which we did in the United States, frankly, it was done because Congress wanted to close our Vet Center program in the 1980s, thinking, well, it's 10 years after Vietnam ended. They must be over it by now. It was the largest epidemiologic study ever done of a single mental health issue, in this case PTSD. And one of its most important findings is that the strongest predictor of whether a person who served in Vietnam continued to have PTSD or ever had PTSD was the level of perceived social support from their family. It wasn't even the real social support from their family, but if the veteran believed that their family had their back, they were less likely to ever get PTSD or continue to have PTSD. And, you know, for all the interesting things about the biology of PTSD, which floods the journals, this finding, I think, is at least equal to any of them. And what are we doing to put this finding into effective action to help people? Not enough yet. And then you consider that, thanks to my friend, colleague Becky Porter, that I wrote this the Communities of Care article with, 57% of everybody in the military, she just said, I would look up how many people in the military are the children of veterans. 57% of everybody in the United States Army, which is our largest force by far, are the children of veterans. So we have a military dynasty. Plato predicted in his Republic said you might want to have a military segment of your community. And what are we doing about the intergenerational aspects? And again, I want to be clear, I'm not pathologizing children of veterans. We have an opportunity to build, a much more resilient force if we pay attention to how these kids are being raised. And are we taking best advantage of the fact that we have their parents and we could be doing something for these kids? Probably not. We're not taking advantage of that at all. And military families face predictable stressors. The deployment cycle, we stopped talking about just PTSD and looked at deployment stress. And there are different stresses at different points. And the deployment cycle includes pre-deployment. When a parent first finds out they're going overseas, and they get notice a while in advance, then they usually go away for very long training before they actually deploy. And during that time, there's a lot of stress. Then they actually deploy. And by the way, they almost never end up doing what they trained to do. But that's just the military. But they spend that time overseas, long separation. Most people who serve overseas will tell you, yes, people were shooting at me. Yes, things got dangerous. Yes, I was blown up. But I really feel sorry for my spouse at home because they had all the hard work. They really, and they believe this. They really do. And I think it's often true. In many ways, the spouse at home has a harder time. And then there's the post-deployment readjustment. And so many families break up. And so many children run into significant problems. Other stresses include starting a new family, or every 2 years on average, our military members move to another city or another country through their postings, or transition out of the military, which is something Dr. Davovich and I are working on now. Well, with all that experience, I decided to go to Washington and fix everything, and you can imagine how well that went. But in addition to responding to the crisis of the day, like what was some newspaper article in a newspaper I wouldn't read myself, but somebody wrote an article and I'd have to be called down to somebody's office and explain this and then write something about it and do something about it. I became increasingly aware of the history of the VA. And the fact is, in the aftermath of World War I, our VA was conceived of not as a bunch of hospitals, but as a population health system, which not only provided high-quality care, that was culturally competent and clinically competent for a military population. That's a special set of problems. But which also focused on prevention, resilience, health, and well-being across American society. And that vision had eroded. The people who were running our hospitals thought of themselves as just hospital directors. And if they had all the things that went in the hospital, that was enough. And that isn't enough. It doesn't create these communities. It doesn't focus on resilience. It doesn't employ a population health perspective. And in fact, the biggest problem I had to deal with, the Secretary of Veterans Affairs would come back from the White House a couple of blocks away and say, well, the President told me I'm being judged on how many veterans are committing suicide. And the fact is, of the 20 United States veterans and military members who die every day on average by suicide, which is a horrifying number, 14 of those veterans are not in our system at all. They are not patients in the VA health system. So the fact is, and it certainly came home to me, that I could do the best job in the world, I could train the best people, we could have the best equipment and all the space. It didn't matter if 14 out of the 20 people who most needed us never came to us. And to me, that is the ultimate proof that you need a population health system just to reach these people, let alone change that dynamic. So we need a population health approach, which meets its target audience wherever they might be, even if they never came to our health system. And I want to say a word about that. So again, we start with the veteran, and we're supposed to be a veteran-centered and veteran-driven program. But as I say, the veteran often isn't with us. And then we take that veteran and we build a health system around it with these elements: hospitals, clinics, call lines, and the vet center program I talked about, all of which are outstanding. I'm very proud of all of them, but which, as I say, have proved to be insufficient. And yet most of our administrators think, well, I built that, I'll just polish the floors and people will want to come, improve the food. But a population health system requires reaching into other places, colleges, as I mentioned, workplaces, the legal system. So many veterans end up in our legal system for various reasons, and by the way, the most common reason by far are crimes associated with homelessness, because these people have fallen through every social web that we could build. They lose their jobs, they drop out of school, their marriages fall apart. It's about a 10-year tailspin into homelessness. And so the homeless systems. Veterans organizations are a place to reach out, because they'll go there before they come to us. Congregations, as I've mentioned. So those are places to reach, and we started to engage with them. But then we began to think about special populations, which includes a Special Forces group, which is a unique group of people. Native Americans, just as you have here with the Aboriginal community, Native Americans in the United States serve at the highest rate of any population in the U.S. and have the highest rate of PTSD, largely because they were underprivileged before they got into the military. They go back to underprivileged neighborhoods where they haven't got a chance of getting a job, where substance abuse is rife, and they really haven't got much of a chance then either. So we're reaching into those groups and creating new opportunities. Women veterans. Women veterans in the U.S. are more likely to be homeless than male veterans. The rate of suicide among women veterans has increased, I think now, sixfold. And the reason being, sixfold above the average American woman suicide. And the reason is they use firearms. Firearms are 90% lethal in a suicide attempt. The usual means by which women in America commit suicide is more like 10% effective in terms of lethality. So women veterans are dying at a much higher rate. And so we need special outreach, and rural veterans. But then the real population health issue. There are a lot of people in this system. I've shown you structures, I've shown you abstractions. There are individual people, and it's beyond my PowerPoint skills. But the fact is, at least in the U.S., about 3 out of every 10 dots here would be a veteran and their family members. In a nation of, and then they're not just the people in our system, it's the people all over our nation. In a nation of over 300 million people, if 1% of those people were to help us in reaching out to veterans, we would have a workforce much bigger than anything the VA could ever muster. And this, I think, ultimately is the key. And I say that because in the aftermath of World War I, it wasn't because government wanted to do this job or knew how to do this job. It's because citizens just like this forced government to do this job. It's because a few enlightened people reached out to the American citizenship, got their attention, and said, you must do this, and that's why government did it, and that's where we are today. But that's a flame that has to be rekindled. And in fact, my retirement is largely to work on exactly that. So just imagine if within this group, I don't know if you can see my cursor, even a few of these people were to form little groups sitting around their kitchen tables and say, you know something, we all go to Dr. X down the street. Dr. X has never asked any of us that we serve in the military. We're going to go there and say to Dr. X, I want you to ask everybody in your practice. I want my local hospital to ask everybody. I want my employer to ask everyone if they served in the military. I want my public school to identify military children and honor them and their families, and also reach out to them and help in any way possible. If people did whatever was sort of low-hanging fruit for them, it would amplify our ability to honor and assist service members and veterans logarithmically. So these joint efforts are now, new joint efforts are now underway in Australia, Canada, and the US, and again, Paula has really spearheaded this, to develop population health strategies based on process, and working with the theory that she developed, looking at the moment of separation from the military, and the huge change in identity that comes when you go from a culture that is altruistic, other-centered, I will do this for my buddy, not for myself, to a world where you're expected to be self-centered and individualistic. and frankly you lose the support of that community, it's a tremendous shock to go back into the civilian world, and a great place for us to begin to intervene. Essential, this is a focus on well-being as opposed to sickness and disability. And to jump ahead, it leads to this idea of whole health and well-being. And this is a concept that is used here in Australia in very similar terms to what we use. But to give you a sense of well-being, well-being isn't about a sickness system, it's about a health system. It involves aspects like, are you sleeping? Are you eating? Are you employed? Are you having good relations with your family and friends? Do you have ways of coping with stress and anxiety? And ultimately, the question we're trying to ask veterans, and this is a national initiative in the VA, what matters to you in life? Not how do you feel, but what do you want to be around for? What do you want to do? And if you can't do it because you're having problems, how can we help you overcome those problems? And not just in the health arena, but how can your boss help you? How can the clergy help you? How can your wife help you or your husband? How can you help your kids do what they want to do? We've actually developed in our VA an index for this, a new validated measure called the WellBeing Inventory, which, by the way, is free of charge. Everything our Department of Veterans Affairs does is in the public domain, and which we're beginning to use in Australia, we're hoping to use and hope to use in other nations as well, and compare our military and their families on well-being as a measure. It's not enough to say, do you have PTSD or don't you, and then send the people who don't home. Are you living a good life in your terms? And this is the way to find that out. And when we find out people aren't, figuring out what's wrong and then figuring out which systems will help them. These are just direct quotes actually from what we send to veterans and on our website, and I've given you a website there. But the bottom line is we're trying to turn the VA into a community of care, but only one small hub in a much larger community of care. And that is the basic idea, and I'll stop there, and I've still left you a few minutes to ask questions or correct things. Thank you very much.
Thank you very much, Harrell. I admire a man who's in his retirement decided to fix the entire United States healthcare system. That was a wonderful presentation. Very, very thought-provoking. We've got plenty of time for questions if people would like to start.
Hi, Bob Reason, retired practitioner. I'm very interested in what your resilience studies might have shown, and do you believe you can be trained in resilience?
All right, short answer, I don't believe you can be trained easily in resilience. The U.S. Army created a program called Comprehensive Soldier Fitness, and I think it was an immense waste of time. The idea was to model what really strong people do and then train people to do it. And the biggest problem with it is if you fail to feel that you succeeded, then it was your fault. And I think that just compounded the sense, you know, there are really hard things in the world, and service members know that better than most people. I don't think that's the aim. But the aim to be resilient. What resilience really means is you take the blow and you come back. And I think we need to build that mindset as opposed to, I will make you so strong in advance that nothing is going to hurt you. I think that was an awful idea, but you know, I'm 3,000 miles away, I can say that.
So can I, on that note, I was struck by the comment you made about resilience and the perception of family support being a key factor in whether you do or do not suffer from PTSD. So my understanding, somewhat limited though it is of American military history, is that the Vietnam War was obviously a very controversial war, was here in Australia, and the veterans were notoriously felt unsupported.
Yes.
By society when they returned. Afghanistan and Iraq, still controversial, but it seems to me that was a difficult period, and those veterans didn't suffer the same sort of attitudes when they came back. So, are there differences in the rates of PTSD in those populations? Are there lessons to be learned from?
Actually, there is no difference in the rate of PTSD between Vietnam veterans, which lifetime is about 30%, and the last time we redid the National Vietnam Veteran Readjustment Study, we made it into a longitudinal study, it was about 10%. And we see pretty much the same in Iraq and Afghanistan. But it is true that people now are getting more support. During the Gulf War, the first Gulf War, a lot of the people coming back said, we don't have that Vietnam stuff, and they distanced themselves. They also distanced themselves from talking about it or doing anything about it if they did have the problem. Because again, they felt like they were the standouts. I must be weak. I was supposed to be stronger. By the way, I also want to correct one thing, and I apologize because I'm probably worried about the time more than some of you are, that I do believe resilience is something that can be developed. I do believe, Steve Southwood was mentioned earlier, and Dennis Charney, two old friends actually, and they've written some wonderful works on resilience. Resilience is an important concept. Resilience can be built up. It's just not brittle. In fact, a very important psychoanalytic study of 5 people, as I recall, was done right after Dunkirk. By a woman who at that point was not married. Her name was Rosenberg then. She became Zetzel. And she looked at 5 men that she worked with who were having the most problem after Dunkirk, coming off the beach there, kind of readjusting. And what she observed was that these 5 men all told her that they had never felt fear in their life until then. And anybody who's at Dunkirk would have to understand fear. But she said people who had said, yes, I've been afraid before, or, they were more resilient than the people who said, I never knew fear. And she said there's a brittleness in this, and those people might have gone through life never knowing fear, and great. But this isn't the way to train a military. And I think there's an important lesson there.
Yes? A question around, you spoke about having the ability to look at to sort of develop ways of prospectively identifying PTSD in a cohort. How much work is done around selection of candidates for the military in the US to look at trying to minimise the risk of putting people who may lack inherent resilience into harm's way?
Yeah, it's a good question. The militaries of every nation have often delved into this idea that we're not going to have that. Frankly, one of my heroes said, let's not take people who are truly, mentally deficient, people who have IQs of 70 or less, for example. Let's not put them in, why break people who probably aren't going to be able to cope in those circumstances? But with those exceptions, there's no way to predict how a person will really respond. The United States, in fact, in the British, I once read some British report where they wanted to use a 19th century American way, American Navy way of taking people who wouldn't be able to serve and successfully, and it didn't work. I think it never works. There's really no way to predict who's going to do well. In World War II, again, another hero of mine, Harry Stack Sullivan, had this idea for whatever reason that homosexuals shouldn't go in the military. Not that he was against homosexuals, he himself was homosexual, but he for some reason believed that they would break down and therefore it wasn't a good idea to put them there for their colleagues or for them or for the nation. And in fact, the system that he developed and worked on very carefully proved not to predict who would do well. It kept thousands of people out of the war who later did go to war when they finally said, that's enough, we can't do this anymore. And those people did as well as anybody else. There's just no lesson in history that will let us predict who will do well and who won't. But I would say someone who clearly already has a psychotic disorder, severe depression that doesn't respond. We now send people on medication for depression into war, but we don't send people who are psychotic on antipsychotics into war. It's not a kindness. And remember, it's not just a matter, even you can say it's a matter of democracy and respect for people. I do respect people who have schizophrenia very much. They lead tougher lives than most of us will ever understand. But to send them into war would be totally insensitive to their needs and would also be dangerous for the people around them who depend on them. Not because they're psychotic, but because they may not respond well in that circumstance.
Hi, Derek McManus. You mentioned that there's a lot of veterans' children going into the service. How do they fare and how are they represented in the PTSD studies? Are they similar percentages to the average population, or do they have less? Do they have more?
Not nearly enough is known. I recently found myself on the board of a new program on the intergenerational legacies of trauma to try to understand this. And in fact, there's a much bigger literature on children of Holocaust survivors all over the world, quite a few here in Australia. But the literature is very mixed. Some of it's seeming to show that people who are the children of survivors of extreme trauma do better in life. And some showing they have more problems with anxiety or depression. One of the more interesting findings I just read recently, and I think is a good insight, is that they do better in life until they run into a wall, in which time they do worse in life. There are a lot of superachievers who have done extremely well in life who are the children of Holocaust survivors, and I think of military members too. But then if something happens that undoes that superachievement, which itself may be a kind of compensation, it's real, you can't pretend to be something special. But if something then says maybe you're not special enough, they may fall further from a greater height. But this is something we're just beginning to understand, and almost nothing's known. We did a study, because a medical student wanted to do the study in his third year of medical school at Duke. We looked at the MMPI's, the Minnesota Multiphasic Personality Index, which is an overall measure, and a pretty well-validated one. It was the MMPI-2, in fact, which was brand new at that time, of all kinds of psychiatric issues. And we asked Vietnam veterans to take PTSD scales and other kinds of scales, depression, substance use, and we asked them to give to their children the same measure. And we wondered if the children would look like the parents, and in fact they didn't. The children, and the children of parents with PTSD also didn't look like their parents. On the other hand, the children of people with PTSD had all kinds of vaguely strange MMPI things. They weren't insane, they weren't damaged, but they were different. But there was no pattern. By the way, in the same way that people often look at the sleep architecture of people with PTSD, people with PTSD don't have normal sleep architecture. They don't sleep normally. But there's no one pattern to it. And, you know, I think there's a truth there about how people adapt. And it's highly individualized. It's not as simple as we'd like it to be. If it were simple, we would have solved it. We would have seen it and solved it by now. People need individualized approaches. But that's why it takes so many people to get this job done, to do that individualized work.
If I can just continue on the same vein, what about the guys and girls from Special Forces? Presumably they're under higher levels of stress, higher levels of just training environment, and maybe see more traumatic events. Are they higher represented in the numbers of people with PTSD, depression, anxieties as well? No, there is some correlation between the severity of combat exposure and the duration of combat exposure and developing PTSD. It's not as strong as I said about social support. The Special Forces people are highly selected, and they also have different experiences very often, and they also have a lot more support within their system. Where I see people, and this is just, I'm going to respond to my own experience because there isn't good literature on this, where I see them running into trouble is later in life when they can no longer get access to their buddies, when they no longer can be functional at that elite level. Then sometimes they become despondent because they don't feel like themselves anymore. And not only were they truly exceptional people, but they were honored and understood, and in their roles they performed exceptionally. And the rest of their life may not give them those opportunities, and that can be very challenging for them.
Good evening, sir. Jordan and Hydro here from the 7th Battalion. We're currently trying to develop a welfare plan that basically prepares soldiers and their families to best deal with matters like this. As we were speaking before about resilience, saying that you can't just train someone to be better and then take that hit and be fine with it. You're saying to take the blow and come back. Have you witnessed any good training programs, or how do they do it in the States with actually actively training soldiers so that when they get hit, they're able to recover and get on with the job?
Well, this is what we're working on. I wish I could say, and it seems perfectly logical, we would have fixed all this by now. But no, we haven't. But this is where Paula Davovich and I and our colleagues in Canada are looking at building these systems. If you ask me, what is the core of that system? It wouldn't be something a doctor does. It would actually be finding a way within the military system to prepare people for leaving it from the time they enter the system. Just the way that, my medical school, the Alumni Association takes you for a barbecue before you ever start class. And then they say to you, we're doing this because you may think it's a long time, but you're going to graduate, and we want you to join the Alumni Association. And we want to support you in your role as a doctor when this happens. The military should be doing that from day one. If this is successful, you might have a 20-year career, but you're going to become a civilian. Quite frankly, in my experience, when you meet even exceptional military people, the one thing that puts, glazes over their eyes is when they anticipate leaving the military. Because it's like nobody who's in the military has ever left the military. and it's like, what do I do? Where do I fit? That plan can be developed. The real core, though, I think, is making sure that military members and their families know what power they have to overcome these obstacles. Again, I think resilience is a hard thing, but they really do have power to overcome these things. Frankly, the Sesame Street program we were on was one of the most important, I think, resilience attitudes, because it showed military families that, yes, you may have long deployments. Kids may not know what to do with their parents, and parents may not know what to do with their kids when they get back. And besides, like, kids now grown and doesn't need the parent the same way. And but you're a family. You're going to get through this. And because you're a family, you're going to get through this. And you guys have what it takes to get through it. That's the essential message. And I think that's something that we have to find ways to communicate and roots to keep putting that into military culture while people are in the military. Again, I am in awe of our service members and their families. These are wonderful people who are doing incredible things. And the real pity is they don't always realize their own strengths. They know their strengths in certain elements, but they don't realize what they could accomplish in this particular mode. So we have a lot of work to do, and I wish it had been done already.
Excellent. Well, folks, that's I think that's a good note to finish on. The enormous respect we have for service members and their families. I think a great lecture, a great public lecture, is one that makes you walk away full of questions, full of ideas, full of enthusiasm and inspiration. And I think we all feel that tonight. A beautiful talk, incredibly thought-provoking from Harrell. We thank him for spending the time with us and for his 30-odd years of
very odd, some of that.
of service and work and research and ongoing efforts to change the world. We very much appreciate it. Please join me in thanking him.
When it's being presented, but I think it's always nice to have a stage.
See you, mate. Thank you.
Thanks, John. My old man was there. My mother almost I grew up with all this and really right middle Christianity. I know I go back to your grandfather into the league. This is the state. We've all been in it.